Welcome to the Deep Dive, the show where we really try to cut through the noise and get you truly well informed, making sure you're always ahead in your clinical practice. Today, we're looking at something that seems quite minor, actually a pediatric injury that, well, quite often hides a much bigger threat. We're calling it the silent threat under the nail. We're talking about Seymour fractures. Now, it's an injury that's been described for ages, since 1966, in fact, but it still seems to get misdiagnosed or, perhaps worse, underestimated quite a lot. And for kids, this can unfortunately lead to some pretty severe long-term problems. So our mission today is to give you, our dedicated medical professionals out there, a really clear, comprehensive understanding. How do you spot these tricky injuries? How do you manage them effectively? And crucially, how do you prevent those serious consequences? We'll be drawing on the latest clinical insights and, importantly, lots of practical experience. And joining us to guide us through this vital topic is Professor Mo Imam. Professor, your expertise in pediatric orthopedics and your knack for making complex stuff really clear and actionable is exactly what we need for this deep dive. It's brilliant to have you here.
Thank you. It's a real pleasure to be here. And yes, it's a topic that seems straightforward, but it's definitely got its pitfalls, diagnostic traps, and the potential for quite serious long-term issues if it's not picked up and managed correctly and quickly. So yes, I think a good grasp of Seymour fractures is pretty fundamental for anyone in A&E, primary care, or pediatric orthopedics, definitely. The details matter.
I couldn't agree more, Professor. That's exactly why we're dedicating this deep dive to it. So let's start right at the beginning. When we say Seymour fracture, what exactly are we defining? What makes it, well, distinct?
Well, the interesting thing, and often where the confusion starts, is how specific it is. Fundamentally, it's defined as an open, displaced, distal phalangeal physial fracture.
Right.
But the absolutely crucial bit, the bit that often gets missed, is that it always comes with a nail bed injury. It's not just associated, it's part of the definition. The fracture happens, the nail bed gets damaged. Simple as that. And critically, it only happens in kids. Skeletally immature individuals whose growth plates, their physes, are still open. You just don't see these in adults once those plates have fused.
Right. So it's never just the bone. The nail bed is always involved. That definitely makes it sound more complex straight away. And that physeal part flags it as specifically pediatric, hitting the growth area. How does it usually classify using systems we know, like Salter-Harris?
Exactly. The physial involvement is key. It's usually a Salter-Harris type 1 or type 2. Just quickly, type I is straight across the growth plate. Type 2, the most common type overall actually, goes across the growth plate and chips off a bit of the metaphysis, the main bone shaft next to it. Sometimes you see that little triangular piece, the Thurston-Holland sign, on the X-ray. Occasionally you might hear it called juxtaepiphyseal. That just means the break is right next to the growth plate in the metaphysis rather than purely through the plate itself. But look, whatever the classification, the defining thing for a Seymour is that combination. The bone injury and that nail bed damage. That's what sets it apart.
Got it. And the word open, that's critical too, isn't it? What makes it inherently open? Because as you said, it might not look like a big obvious wound.
This is a really subtle but vital point, and it's why things go wrong sometimes. It's considered open because the injury always involves tearing the nail plate away, usually proximally, and a cut, a laceration in the nail bed underneath. Think about the anatomy there. The nail bed, especially the germinal matrix where the nail grows from, sits right on top of that distal phalanx and its growth plate, is practically stuck to it. So when that fracture happens and displaces even just a tiny bit, it rips those soft tissues, specifically the nail bed. And that tear, however small, creates a direct path from the outside world with all its bacteria straight into the fracture site. But it's effectively, a wound in the bone. That's precisely why we have to treat it as an open fracture right from the start. Doesn't matter how small the cut looks. It's a principle.
That's a really critical distinction. It's not about how bad it looks, but that communication pathway and the infection risk. Okay, so moving on slightly, how common are these? Do we see them a lot in pediatric practice?
If you look at all kids' hand injuries, Seymour fractures are actually more common than many people think. They make up about 20% to 30% of all phalangeal fractures that involve the growth plate in children. So it's not some rare, weird thing. It's a significant chunk. Which means really every A&E doctor, every orthopedic trainee, every GP seeing kids needs to be aware of this. It's sort of bread and butter in some ways, but with potentially nasty consequences if you miss it.
20 to 30%.
Yeah.
Yeah, that's definitely significant. Not rare at all. And are certain fingers more likely to get injured?
Yes, there's definitely a pattern. The middle finger gets it most often. The thumb is also quite common. We see classic stories all the time, don't we? A 10-year-old boy slams his little finger in the car door, comes in, bleeding everywhere, finger looks bent, nails a mess. Or maybe a teenager playing football gets her middle finger crushed in a tackle, comes in later, bit of dry blood under the nail looks a bit lifted at the base. Those are the classic flags for a Seymour. See them all the time on a Friday night in A&E.
Yes, car doors. They seem to feature quite heavily in these stories. So apart from those classic examples, what are the general ways these injuries happen?
Yeah, overwhelmingly it's direct trauma. Crush injuries, as you said, fingers slammed in doors, that's a big one. But also things getting dropped on fingers, getting caught in things, sports injuries, a stray ball hitting the fingertip just wrong, gym equipment accidents. What's also quite interesting, actually, is some recent work suggesting they might be getting a bit more common. And that could be linked to, changes in how kids play, leisure activities. One study mentioned hoverboard injuries, specifically kid falls, fingers get trapped underneath. So it just shows we need to keep our eyes open. Things change, mechanisms evolve. It's not static.
That's a really comprehensive picture of the injury itself. Okay, let's move on to the tricky bit, how it presents clinically, because it often gets confused with something else, doesn't it? The mallet mimic. This is where it gets difficult.
Exactly. This is the real diagnostic challenge, the pitfall. Even for experienced clinicians, what you see is the distal phalanx, the very tip of the finger, is often flexed. Drop down, it looks exactly like a classic mallet finger. And that's the trap. Because unlike a true mallet finger, which is usually about the extensor tendon rupturing or pulling off a bit of bone, in a Seymour fracture, the extensor tendon itself is usually fine. It's intact.
Right, so it looks like a mallet, acts like a mallet, but the cause is totally different. So why does it flex like that if the tendon isn't the problem? What's the mechanism behind this pseudo-mallet thing?
Well, it's down to a really specific and quite neat, actually, anatomical imbalance of forces. It's unique to the growing skeleton. You see, the extensor tendon, the one that straightens the tip, attaches to the epiphysis, that little cap of bone at the very end, beyond the growth plate. But the main flexing tendon, the flexor digitorum profundus, or FDP, attaches to the metaphysis, the main shaft of the bone, before the growth plate. So when you get a fracture through or right next to that growth plate, separating those two bits, you get these two strong tendons pulling on different fragments. The extensor pulls on the little end piece, the flexor pulls on the main bit. They're pulling against each other across the fracture line. The flexors pull on the main bit, combined with the instability, just causes that distal fragment to flex down. It actively stops it lining up properly. It's like a little tug of war, and the FTP wins.
That makes perfect sense. The fracture creates the weak point, and the tendons pull the pieces apart, causing the droop. And I've often heard that true tendon ruptures are actually quite rare in kids because the growth plate is weaker than the tendon. Is that right?
That's absolutely spot on. It's a fundamental principle in kids' trauma. We teach it all the time. In many injuries in children, the growth plate is the weakest link in that whole bone-tendon complex. So when you apply significant force, instead of the tendon snapping or pulling off the bone, the force goes through the weakest point, which is the physis, and you get a physeal fracture instead. So yes, physeal fractures, like a Seymour, are much more common than pure tendon avulsions in these sorts of mallet-type injuries in kids. Knowing that helps keep your suspicion high for bone injury, even if it looks like a soft tissue problem you'd see in an adult.
That's really fascinating and so important for diagnosis. Okay, so apart from this pseudo-mallet look, what other key things should we be looking for when we examine the finger? What are the really distinctive clues?
Well, beyond the obvious flexed fingertip, the DIP joint, you'll almost always see bruising, ecchymosis, and swelling around the finger. Often more noticeable on the back, the dorsal side. But the nail presentation is probably the most distinctive clue, really critical. Often the nail plate itself looks like it's sitting on top of the skin fold at the base, the eponychial fold, or it might even be pulled right out from under it. This can give a funny look, like the nail is suddenly longer than normal because it's not tucked in properly at the base. Plus, you might see dried blood right at the nail base. Or the nail might look obviously lifted up, partially avulsed. Like that boy with the car door injury I mentioned, the bent tip, the swelling, and that lifted bleeding nail base. That combination just screams Seymour.
So it's the mallet look plus something going on with the nail displacement, blood at the base.
Right.
But can it be subtle, or is it usually pretty obvious?
Good question. And that's why they get missed. The presentation can vary massively. You can have really subtle nail bed signs, maybe just a tiny little cut, or a speck of dried blood near the nail fold. Barely noticeable. Or, at the other end, you can have grossly displaced fractures where you can practically see the bone sticking out. It's this huge range that makes careful diagnosis so important. It's often those subtle ones that get missed or dangerously underestimated, and they're the ones that run into trouble later because treatment was delayed.
So, given that variability, what's the absolute key diagnostic tip, especially for someone in a busy A&E? What's the trigger for a full workup?
All right, this is probably the single most important clinical takeaway, I think. Any child who comes in with what looks like a mallet finger, that droopy fingertip, and they have any blood around the nail fold, doesn't matter how little, even if it's just dried blood, you must investigate them thoroughly for a Seymour fracture. We sometimes call it the Seymour sign, that specific combination. Mallet appearance plus any sign of nail bed injury or blood. That's your massive red flag. Don't ever just assume it's a simple nail injury or a standard mallet. Getting that distinction right can prevent lifelong problems.
That is incredibly clear. The Seymour sign, that's easy to remember. Okay, so we suspect it clinically. What imaging do we need to confirm it?
X-rays. Standard radiographs are what you need. But, and this is crucial, you need the right views. The AP view, the front-on one, can often look surprisingly normal. There isn't usually much side-to-side shift. But the lateral view, the side-on view, is absolutely essential. It's much more sensitive. You simply have to get a good lateral. On that lateral view, you'll typically see the growth plate looks widened, separated. You'll see the displacement between the epiphysis, the end bit, and the metaphysis, the main shaft. And critically, you'll see that characteristic flexion deformity at the fracture site we talked about, the tip pointing downwards.
Yeah.
That confirms it and shows you how bad the displacement is.
Right, so don't be fooled by a normal AP. The lateral is the key. And how does that lateral X-ray help us definitively separate a Seymour from a true mallet finger, the main differential?
The lateral X-ray is paramount for that, absolutely. In a true mallet finger, the break, if there is one, usually involves the back, the dorsal part of the distal phalanx, and crucially, it runs into the joint, the DIP joint. It's an articular fracture. In contrast, with a Seymour fracture, the fracture line goes across the physis, the growth plate, and it stops before the joint. It doesn't go into the DIP joint space. It's purely a physical injury. That difference on the X-ray, does the line cross the growth plate but spare the joint? Tells you definitively if you're dealing with a joint injury, mallet, or a growth plate injury, Seymour. It completely changes your management plan. See that line through the physis, respecting the joint. Almost certainly a Seymour.
Excellent. That distinction is crystal clear. So we've got the diagnosis. Let's talk management. What are the absolute core principles here, especially remembering what you said about it always being an open fracture?
Right, the classification is everything here. Seymour fractures must be treated as open fractures, no question. Because this risk of infection is so high and potentially severe, given that communication through the nail bed tear. And the reason for that risk, and also for other long-term problems, is the potential for soft tissue getting trapped in the fracture. Specifically, the germinal matrix, that nail-growing tissue. It can get pinched between the bone ends. Now, that's not just a small problem. It physically blocks you from reducing the fracture easily. It directly risks causing a permanent nail deformity because the matrix is damaged. And perhaps worst of all, if that tissue gets stuck in there, it can stop the bone growing properly. It can cause premature growth arrest, leading to a short finger later on. So you'd really early aggressive management, treating it like any other open fracture to stop these nasty, often irreversible complications.
Okay, so multiple goals. Stop infection, get the bone lined up perfectly, and protect future growth and function. What are the immediate first steps in A&E once you've diagnosed it?
Immediate action is key. First thing, absolutely first, is get parenteral antibiotics in, straight away. We usually go for a first-generation cephalosporin, something like cefazolin, 25 milligrams per kilo, IV, as soon as you suspect it, really. Then they'll need a course of oral antibiotics when they go home, usually 5 to 7 days, maybe up to 2 weeks in some cases, something like coamoxiclav to cover the likely skin bugs. At the same time as the antibiotics, you need good initial wound care. Wash out the nail bed thoroughly with saline. Just physically cleaning it makes a big difference to the bacterial load, reduces the infection risk.
That sounds like standard open fracture stuff. But what about actually fixing the fracture? Can these ever be treated just in A&E, or is it always a trip to theaters?
Good question. Look, for a really minimally displaced closed Seymour fracture, and I have to say those are pretty rare given the definition involving the nail bed tear, maybe, just maybe, you could try a careful closed reduction splinting in A&E. But what's really interesting, and a bit of a shift in practice recently, is the growing evidence about treating even straightforward open Seymour fractures right there in the emergency department. Some big pediatric centers have shown that actually a good chunk of acute Seymours can be managed perfectly well in A&E without needing a formal operating theater slot. They've got protocols where trained senior trainees, properly supervised, of course, can do the procedure there, usually under conscious sedation or using a good digital nerve block to numb the finger. And that's got huge advantages, hasn't it? Frees up theater time, less anesthetic risk for the child, potentially much quicker treatment, get them home sooner, shows how pathways can evolve.
That does sound like a really positive development, streamlining things. But I guess there will still be cases that definitely do need formal surgery. When do you absolutely need to get the hand specialists involved and head to the operating theater?
Oh, absolutely. While ED management is expanding, some cases definitely need the operating theater. And yes, a hand specialist or a pediatric orthopod with hand expertise really should be managing these because of the potential downsides. The clear reasons to go to theater are obvious open fractures with lots of contamination or visible bone, displaced fractures you just can't get reduced properly or keep reduced in A&E, fractures that are clearly unstable, chronic ones, meaning they've presented late, say more than 24 hours after the injury, or any case with big extra cuts, gross contamination needing a formal washout, or significant instability you can't control with just a splint. The theater just gives you the ideal setting for a really thorough look, making absolutely sure no tissue, especially that germinal matrix, is trapped.
Right. So once you're in theater, what are the key steps? Walk us through the surgical procedure.
Okay, so the surgical approach is pretty standard, aiming for meticulousness. First, you carefully take the nail plate off. That gives you clear access to the nail bed underneath and the fracture itself. Then, the absolutely critical step. Explore the fracture site carefully. Make sure there's no soft tissue trapped in there, especially bits of germinal matrix or nail bed. That's often why closed reduction fails and what causes problems later. You can sometimes sort of milk the tissue out by carefully bending the finger or gently pulling on the fingertip fragment. Once you're happy it's clear, you give it a really good washout, irrigation, and debridement to get rid of any dirt and bacteria. Reduces the infection risk again.
Okay, so clean it out, make sure nothing's trapped. Then what?
Then you line the fracture up anatomically. Reduce it carefully. If it feels unstable, which it often does, you usually put a K-wire in, a thin metal pin. Typically run it sort of diagonally across the fracture line and often across the DIP joint as well, just to hold everything perfectly still while it heals. Usually put it in from the tip backwards, across the joint and the physis, and bury the end under the skin so it doesn't catch. Interestingly, the nail plate itself, once you put it back, can actually help hold the reduction like a little splint. Some older techniques even use things like a simple needle for unstable ones, but K-wires are more standard now, more robust. And then, crucially, if the nail bed was torn, you repair it meticulously. Use really fine dissolvable stitches, like a 6-0 or 7-0 chromic. Then you either put the original nail plate back if it's clean and usable, or you put a little stent in the nail fold. Often just a piece of the sterile suture packet foil. That stops the skin fold sticking down onto the raw nail bed and keeps the channel open for the new nail to grow properly. Reduces the risk of nail deformity later.
That's a very clear walkthrough. Thanks. Since these are kids, does age affect the anesthetic choice much?
Oh, definitely. Age is a big factor. Little ones, toddlers, preschoolers, they almost always need a general anesthetic in a proper theater. They just can't cooperate. You need them perfectly still for delicate work, and it's best for pain control. But for older children, adolescents who are more cooperative, you often can manage them in a treatment room, or even A&E like we were saying. With good pain relief and a really effective local block, like a digital nerve block at the base of the finger, that numbs the whole finger really well, avoids a general anesthetic, which is always preferable if you can.
Right. Less invasive is always good. Now, you often see studies where surgically treated patients seem to have more complications. Is that really down to the surgery itself, or is something else going on with Seymour fractures?
That's a really important point about how we interpret studies. It's about selection bias, isn't it? While yes, some studies might show higher complication rates on paper for the surgical group compared to the non-op group, that's very often because the injuries that needed surgery in the first place were simply much worse, more complex, more severe. Think about it. The straightforward, minimally displaced, cleanish ones are more likely to get managed non-operatively or in A&E. The ones ending up in theater are the really displaced ones, the contaminated ones, the late ones, the ones with trapped tissue. They are inherently tougher cases. So you can't just directly compare the complication rates without accounting for how bad the injury was to start with. The surgery is usually a response to a more severe injury, not the cause of the higher complications, if that makes sense.
Yes, that makes perfect clinical sense. The surgery reflects the severity. Okay, let's shift to the potential problems, the long-term outlook. What are the main complications we really need to worry about with Seymour's?
The number one worry, and the most potentially devastating, is infection, as we've mentioned. It can range from fairly superficial stuff like cellulitis around the nail, paronychia, to really serious chronic osteomyelitis that's a deep infection right in the bone. And the risk of osteomyelitis goes way up if treatment is delayed or if the initial washout wasn't thorough enough. That's why those immediate antibiotics are absolutely non-negotiable.
So the longer it's left, the bigger the risk of that deep bone infection. What else can happen long term?
Well, another common one is nail dystrophy. Basically, permanent problems with how the nail looks and grows. It can be ridged, split, thickened, sometimes even completely absent. That's often down to direct damage to the nail bed during the original injury, even if the fracture itself is managed perfectly. But perhaps the most critical one in growing children is growth disturbance, physial arrest. That's when the growth plate gets damaged and stops working prematurely, so the finger ends up shorter than it should be, shorter than the others. And it's really important to understand that growth arrest is much more commonly linked to deep infection, especially osteomyelitis, rather than just the fracture hitting the growth plate. The infection poisons the growth cells, so preventing infection is also key to preserving finger length.
That's a vital distinction. Growth arrest is often secondary to infection, not just the break itself. Any other potential complications? Maybe less common.
Yes, definitely. While maybe not as frequent as infection or nail issues, other things can happen. The fracture can slip again after you've reduced its secondary displacement, especially if the fixation wasn't great or the child doesn't follow instructions. You can get non-union, where the bone just doesn't heal, or malunion, where it heals in the wrong position. Both can cause ongoing pain, affect grip strength, change how the finger works, and you can end up with a persistent flexion deformity, that droop, if the reduction isn't held or if there's scarring underneath. All of these can add up to real long-term functional problems for the child.
It really does underline how crucial getting treatment quickly is. What does the evidence actually show about that window for intervention? How fast do we need to act to prevent these problems, especially infection?
The evidence is really stark here. It gives us a clear mandate for urgency. Delayed treatment is probably the single biggest predictor of higher infection rates, especially osteomyelitis. Study after study shows a massive drop in infection if you get those IV antibiotics within the first 24 hours of the injury. Just as an example, one big study found an osteomyelitis rate of only about 3.5% when antibiotics were given promptly and management was appropriate. Compare that to rates as high as Teller. Well, over 27% reported in series where treatment was delayed or antibiotics weren't given properly or the diagnosis was just missed altogether. That's not a small difference, is it? It's nearly a tenfold higher risk of bone infection.
Wow. So that 24-hour window for antibiotics and intervention is absolutely critical, a real make or break time. So what are the overall consequences if a Seymour fracture is missed or not treated properly?
If it's missed or managed poorly, it can unfortunately lead to a whole cascade of pretty unpleasant chronic problems for the child. You're looking at chronic osteomyelitis, needing potentially long courses of antibiotics, maybe even more surgery down the line. Huge impact. Then there's the permanent nail deformity. Okay, maybe not always functionally limiting, but it can cause real cosmetic concerns, self-consciousness, especially as the child gets older. And then, as we said, physial arrest, leading to that permanent short finger. Add all that together and you've got significant long-term functional and cosmetic issues affecting dexterity, what activities they can do, even their psychological well-being, that the hand is so visible, so functional, the impact can be really profound.
A very sobering reminder of why early diagnosis is so vital. You mentioned outcome variability earlier. How do things tend to look long-term, say 2 years down the line, comparing those managed surgically versus non-operatively?
Yes, it's interesting. While surgery is often needed for the reasons we discussed, getting tissue out, stable fixation, the evidence, actually suggests that the functional outcomes, and the cosmetic ones too, at 2 years can be pretty similar between the operative group and the appropriately selected non-operative group. The key phrase there is appropriately selected. If you pick the right patients for non-operative treatment, the ones with minimal displacement, stable fracture, no signs of trapped tissue, they can do just as well long-term as the ones who needed surgery. It really suggests that both approaches have their place, and both can give good long-term results if you choose the right management strategy for that specific patient and their specific injury. It's not that one way is always better, it's about matching the treatment to the injury.
Right. And finally, thinking about function and recovery. What sort of limitations might these kids face, and what does recovery typically look like?
Well, reduced range of motion, especially stiffness at that end joint, the DIP joint, is always a possibility after any significant fingertip injury, Seymour's included. And the functional impact could be significant, couldn't it? Especially if it's the index or middle finger of their dominant hand. Think about fine motor skills. For someone who might want to become, say, a musician, an artist, a surgeon, even just typing efficiently, that precision could potentially be affected. We do have to discuss that with families. But what's really encouraging is what we see in follow-up. While yes, some stiffness can happen, especially after more complex surgical cases, the evidence does suggest that with good management, including proper hand therapy afterwards, these fractures can remodel quite well over time. Often, kids regain really good joint movement and excellent functional recovery. They can manage things like holding a pencil, writing, playing sports without much trouble. And it's worth saying again, because it's so important, that really significant functional problem of physeal arrest, the short finger, that's much more often linked to deep infection, to osteomyelitis, than to the initial fracture itself.
So again, stopping infection is key, not just for immediate health, but for long-term growth and fine motor skills too. Which I suppose brings us to a final thought, perhaps a bit provocative. As healthcare professionals, how can we really take the lessons we've learned from managing Seymour fractures, especially about acting early, about collaborating between A&E and specialists? How can we use those lessons to improve how we approach other pediatric injuries, even ones that seem minor but might have hidden complexities? It's about maybe applying that same level of vigilance, that same proactive, joined-up thinking across the board to get better outcomes for all our young patients, isn't it?
What a thought-provoking note to end on, Professor. A really important challenge for all of us, and it perfectly sums up the core message of this deep dive. We've covered so much today, defining these tricky Seymour fractures, understanding how they can fool us clinically, the absolute must-dos for managing them urgently, and the serious long-term risks. The key takeaways for you listening are really clear. Spot that Seymour sign, the mallet look with nail-filled blood. Get those antibiotics in early, absolutely critical. And make informed decisions about ED versus theater management, always remembering to treat these as open fractures. If you found this deep dive valuable, and we really hope you have, please do think about leaving us a rating and maybe share it with a colleague who could benefit from these insights too. Thank you so much, Professor Mo Imam, for your fantastic guidance and expertise today. It's been incredibly insightful.
My pleasure entirely. It's vital information, isn't it, for better patient care.
And thank you for joining us on the deep dive. We look forward to delving deeper with you next time.